Dr. Mohammed. Welcome, Dr. Mohammed. And I think Dr. Mohammed will start his presentation with us now. Welcome, Dr. Mohammed.
Welcome. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for kind introduction. Thank you, Dr. Fakhr, for your kind invitation. I would like to start my presentation without further ado, talking about non-cardiac indication for anticoagulation. As you know, the most common indication for anticoagulation is cardiac indication, particularly stroke prevention, atrial fibrillation, followed by other indications like VT, aneurysmal thrombosis, etc. So my objectives gonna be about journey of on new oral anticoagulant therapy or DOAC of a patient through different health setting, discussed in case-oriented and evidence-based approach. I will not cover clinical trials. I just gonna be practical use of DOACs in clinical practice, and I will base my recommendation on ACCP guideline 2016 for VT treatment. This is considered to be the latest because we are anticipating the upcoming VTE clinical practice guidelines from American Society of Hematology this year. So it's good to have an end to journey toward, but it is the journey that matters at the end. So I will start by talking about thromboembolic disorder categorized to arterial and venous thrombosis. The arterial, that brain like stroke, TIA, heart, acute coronary syndrome, AFib, which is the most common indication for anticoagulation, mechanical heart valve, arterial like peripheral arterial disease, aortic aneurysm, etc. Then we have, this is my bar talking about venous thrombosis that can be broken down to DVT, B, and unusual site thrombosis, keeping in mind that DVT and B, or venous thromboembolism, account for the vast majority of venous thrombosis, about 95%, more than 95% is venous thromboembolism. Then we have the remaining 5% or less is unusual site thrombosis. And we define, very important, unusual site thrombosis, simply any venous thrombosis that does not affect the lower limbs or the lungs. So anything apart from DVT and PE considered to be unusual site thrombosis. So the venous thrombosis, I already said the VT, DVT, and PE is the most common. Then we have unusual site thrombosis, talking about cerebral vein thrombosis, subclavian vein thrombosis, regional vein thrombosis, Budd-Chiari or hepatic vein thrombosis, inferior vena cava or superior vena cava thrombosis, and you have upper extremity DVT. Remember, upper extremity DVT is considered as unusual site thrombosis. Then we have the subclavian vein thrombosis. You can have inferior mesenteric, superior mesenteric vein, splenic vein, and portal vein thrombosis. Very difficult to cover all these, indicate each presentation of unusual site thrombosis deserve one presentation or webinar. So gonna focus about venous thromboembolism. So talking about venous thromboembolism, DVT and PE, remember that DVT start usually in the distal veins, i.e. below the knee, in about the vast majority of cases, and about 25% of distal DVT, of symptomatic distal DVT, it might propagate and extend to the proximal vein. So we know that distal DVT is vast majority, about 90% of the cases, and about 25% of symptomatic distal DVT, it can propagate to the lower proximal vein, the femoral iliac, external iliac vein. And if you have proximal DVT, the risk of embolization to the lung about 50%, 1 out of 2, in spite of absence of chest symptoms. It's not necessary to have chest symptoms to have PE. So this is based on clinical studies, and this is very important implication. So remember that distal DVT, sometimes if a patient is presenting with a DVT, classical DVT symptoms, and they do Doppler ultrasound and it's negative, it does not rule out DVT because might be distal, and we know the sensitivity for Doppler ultrasound below the knee is low, about 30%, but sensitivity of Doppler for proximal DVT very high, about 90%. That's why if you suspect a patient with a DVT with a negative Doppler, you have to repeat it in a week time. A week time, it will propagate the distal DVT to proximal DVT. And very important implication, what I said, that if you have proximal DVT, about 50% they have pulmonary embolism, because I just, one patient referred to me, a patient admitted with classical postpartum DVT, and after 3 days, they requested CTPA, and without symptoms, without clinical indication for CTPA. Remember, is contrast, exposure to contrast, to radiation. What happened? It was positive B. Then they labeled the patient as a breakthrough thrombosis. It's not a breakthrough. This is the initial representation of DVT, usually with pulmonary embolism, and they requested IVC filter, etc. It's not indicated. So just to understand, proximal DVT, 1 out of 2 of them, they have embolization to the lung. It could be showering multiple emboli, or it can cause one large pulmonary embolism, causing what we call obstructive shock. So about 10% of symptomatic PE, they can lead to death, and usually within 1 hour. This is what we call it massive pulmonary embolism. And we need to intervene by initiation of life-saving drug like thrombolytic therapy. So this is a very important point. DVT cause PE. If you have DVT with a stroke, you have to suspect what we call patent foramen ovale, because we're talking about non-cardiac indication. So you have DVT with patent foramen ovale. So the thrombus will go through the right ventricle, the right atrium. From right atrium to the left atrium, then we'll go to the systemic circulation, causing a stroke. I remember for VTE in a pregnancy, the most common leg affected is the left leg, because the right iliac artery crossing the left iliac vein, and we call it Maternal-like syndrome. Now, common complications of DVT, what we call, you have the acute complication of DVT is PE, then you have the long-term complication, post-thrombotic syndrome, as you see. And very important, what are the goals of treatment of DVT? Why we treat? We treat to prevent PE, the acute complication, and death. And we prevent the long-term complication, like post-thrombotic syndrome or venous reflux, and chronic thromboembolic pulmonary hypertension. So this is very important. This is the goal of, and again, prevention of the recurrence. So very interestingly, if you have a patient presenting with a DVT, if you give and you don't anticoagulate, you leave the patient without anticoagulation, 50% of them, they have a recurrence. And recurrence, usually the highest recurrence within the first month, about 50%, and 20% in the second and third month. And if you give adequate anticoagulation, so you decrease the recurrence risk from almost 50% to less than 2%. So that's why you need to hit hard, hit early for a DVT, like antibiotic. If you have infection, hit early, hit hard. Very important history of now we are in the era of DOAC, direct oral anticoagulant, or non-vitamin K oral anticoagulant. This is a major revolution in the history of thrombosis. Actually made our life easy for treatment of venous thromboembolism as outpatient, single drug approach. We have, remember the 3 milestones for the anticoagulant drugs. Remember the first one, it was discovered the leech. So the leech, the saliva of the leech has anticoagulant, bivalirudin, herodin. That's why they use leech to prevent graft thrombosis. This is one of the old, medicine, but still used in the current or modern medicine. So heparin, you have IV heparin, 1930. Then you have low-moct heparin, about 1980. Then we have the 2002, the indirect factor 10 inhibitor like condabaronic. Then we have the direct drug. So all direct drug like DOAC from 2010 until right now. And we have the direct 10 inhibitor like apixaban, rivaroxaban, edoxaban, petroxaban. And we have direct 2 inhibitor like dabigatran. very important, this is the direct approach. So we say direct oral anticoagulant because they are a class of anticoagulant. They have a common target. Like as I mentioned, direct 10A inhibitor. So direct 10A, which is sitting at the convergence of intrinsic and extrinsic pathway, or you have direct oral anticoagulant targeting 2A thrombin. Very important. This is advantageous. It can have predictable pharmacokinetic, pharmacodynamic, and decrease the risk of major bleeding. It's very interesting, and it was proven in clinical trials. We have numerous clinical trials. However, interestingly, the random approach or shotgun approach, like for warfarin can inhibit 2, 7, 9, 10. It's very interesting. It is still, effective therapy for certain indication like mechanical heart valve. For antiphospholipid syndrome, DOACs, they fail in, prevention of thrombosis. That's why the, inhibiting multiple key protein decoagulation cascade, it's sometimes useful like antiphospholipid syndrome and mechanical heart valve. So direct oral anticoagulant failed in this indication. Vitamin K, so that's why vitamin K, still around and it will not die. So we need it for very important indication, difficult indication like mechanical heart valve and antiphospholipid syndrome. So limitation of vitamin K antagonists, you are fully aware about it, unpredictable response, narrow therapeutic window, slow onset, slow offset. That's why you need, overlap with rapidly acting anticoagulant. And very important, slow offset before surgery. You need to bridge the patient with low-heparin. That's why with the DOAC, you didn't need to have overlap the drug with rapidly acting anticoagulant because it is has rapid onset at the peak after 2 hours. So this is advantageous. You do need routine monitoring, like for warfarin. Warfarin, you need monitoring with INR, frequent dose adjustment, warfarin resistance. Sometimes you have some genetic polymorphism. You require high dose. I have seen patients, they are requiring 30 milligram of warfarin because of the warfarin resistance, and you cannot switch them because the indication is like mechanical heart valve, numerous drug-drug interaction with warfarin. There are still some interaction with the DOAC, but much less, and numerous food drug interaction. This is with warfarin only. So there are three, approaches for VTE treatment. Classical approach, which is the overlapping approach between rapidly acting anticoagulant like clomifene, anafractionate or fondaparinux with the vitamin K antagonist. So we overlap them for 5 days until we reach therapeutic INR. Then we have the switching approach. This is very important. Switching, you use clomifene for 5 days, then you switch to dabigatran or edoxaban. I have seen patients, they use clomifene in addition to dabigatran for 5 days. This is associated with the high risk of hemorrhage. So this is both are rapidly acting anticoagulant, so it should be switching approach rather than overlapping. Then we have single drug approach for apixaban and rivaroxaban. So very important. This is a case. Remember, if you diagnose a patient with VTE, it's not just a single step. You just prescribe anticoagulant and you send the patient home without follow-up. No, it is from the clinical presentation to diagnosis to again for treatment. Sometimes you need to hospitalize. You have to decide this patient need for home treatment or hospitalization. Do you need to give just anticoagulation or you need to give a thrombolytic therapy? If the patient on anticoagulant requires surgical intervention, what you need to do? How long you stop the drug? Do you need to bridge? Again, dental intervention, which is the most common intervention. What you need to do if the patient with infection, like tonsillopharyngitis, what you need to do in the clinic, and how to deal with complication. So if the patient presents with a DVT, the gold standard test is ultrasound, and for BE is the gold standard is CT pulmonary angiogram. And we don't do any more invasive pulmonary angiogram. This is what we have, CT pulmonary angiogram. Look at it. It is a mimicker of invasive pulmonary angiogram, which we used in the past. So it's obsolete, the invasive. So only we have CT pulmonary angiogram. And the patient, if you have a DVT, see, this is 2016. The DVT, the standard of care is outpatient management. And for BE, only home treatment for or early discharge for low risk PE, and I will tell you how we risk certify PE. So that's the recommendation for management. So for PE, how to risk certify, we call it simplified PE, pulmonary embolism severity index. So any point like age more than 80, or cancer, or heart failure, or tachycardia, or hypotension, or desatting, this is any point, it will give you this is a high risk. So you need to hospitalize this patient. If no point from this is 0 points, so 30-day mortality risk about 1%. But if you have any point, the 30-day mortality about 10.9% or 11%. So that's very important. Very important point, subsegmental pulmonary embolism. This is very clinical dilemma. So do we need to anticoagulate subsegmental pulmonary embolism? Not. So this is very important. Patient subsegment. So what we mean subsegmental PE? So you have, this is the pulmonary, if you can see clear, this is pulmonary trunk. Then you have here, sorry, this is the trunk is not clear here. This is the main, like right main. Then we have, this is interlobar. Then we have here, this is what we call lobar artery. Then we have, this is segmental. Then we have, this is subsegmental. Here, this is subsegmental pulmonary embolism, which is peripheral. So if you have subsegmental pulmonary embolism, do you need to treat or not? So there are situations. So if you have a subsegmental PE without negative bilateral Doppler, i.e. the patient had only subsegmental PE without Dvt and high risk feature for bleeding, like elderly patient. So clinical surveillance is recommended over anticoagulation. But if you have a patient who have subsegmental PE with Dvt, so you need to anticoagulate. If you have subsegmental PE with a patient who have high risk for recurrence, like cancer patient, so you need to anticoagulate. Antiphospholipid, you need to anticoagulate. So it's like case-by-case basis, but generally speaking, we don't recommend subsegmental PE for treatment. I just use this metaphor. If you anticoagulate like elderly patient 85 for subsegmental PE, like you are cracking, a nut with a jackhammer. So this might cause bleeding rather than benefit for the patient. So there are also the clinical practice guidelines for VT treatment. And remember that if you have, like this is, we call it phlegmasia alba dolens. This is a massive DVT with, limb venous threatening gangrene. So you need to use catheter-directed thrombolysis. So this is very important. There are many modalities for catheter-directed thrombolysis. We have many like angiojet, we have mechanical. Very important, if you use this modality, so you should use in the acute phase IV heparin rather than DUAC. And after the intervention, it applies the same duration of treatment. If it is a provoked, you need to treat 3 months. If it is unprovoked, extended. It has no relation with the duration of anticoagulation. This is for a PE. If you have a PE with hypotension, systemic hypotension, i.e. systolic blood pressure less than 90, you need to use thrombotic therapy. So DUAC or VKA from the ACCP guideline 2016, they recommend DUAC over VKA or Warfarin, except if you have the patient with antiphospholipid syndrome or cancer here. But the subsequent guideline, like European Society of Cardiology, yes, they also favor DUAC over VKA, and they mention that you can treat cancer also with lomocribine or rivaroxaban or edoxaban, because apixaban just published a few weeks ago in a New England Journal of Medicine. So that's important. This is the properties of ideal anticoagulant versus currently available drug. So you need about oral, or this is more convenient for patient, no significant food drug interaction, predictable response, no routine coagulation monitoring, fixed dosing, no risk of heparin-induced thrombocytopenia, which is really good for the patient. I already mentioned you have 2 drug approaches, dual drug approach, and you have single drug approach like for rivaroxaban and apixaban. And these are the switching between anticoagulant regimen. This is very important point when you switch from VKA to NOAC. The INR less than 2, immediate to 2.5 immediately or next day. Usually in our clinic, if the INR 2.5 or less, I switch from VKA to DUAC. And if you have parenteral anticoagulant to NOAC like lomocribine, this is very important. If it is like BID dosing, so for the next due dose for lomocribine, you can use DUAC. and etc. For IV heparin, usually you should use it 2 hours before discontinuation of IV heparin because the onset of action after 2 hours. NOAC to NOAC, you can immediately switch from one to the other. So important point, it was mentioned by my colleague that you have to educate the patient because anticoagulant effect drop rapidly after 12 if it is BID dosing or 24 hours if it is once daily dosing. That's why very important to educate the patient. Compliance as patient education is crucial. So you have to give leaflets and instruction at the initiation, patient safety and group sessions, and involve family members. And there is no clinical trial that say that BID or once daily is superior over each other. So both are effective, strategies, and have to discuss with the patient. Patient preference is very important. So this is education. You have to have education materials. You have to make sure about the renal dysfunction. So you have to know that the excretion for rivaroxaban 35%, for apixaban is the least renal excreted 27%, and the bigatran is the highest about 80%. And so they have approved, if you have approved for creatinine clearance more than 15 for apixaban and rivaroxaban, and for the bigatran more than 30. And I'm not sure about doxaban. It is just recently introduced to the market in Saudi Arabia. So when you need to monitor renal function, so if the patient is normal renal function, GFR more than 60 once yearly, if it is the GFR, if the elderly more than 75 or frail, you can do it every 6 months. In our clinic, honestly speaking, we do these patients, we do see them every 6 months with routine lab like CBC, renal, and liver function test. That's I do it routinely for our patient for VT indication. So the contraindication, be careful if you have hypersensitivity to active drug, severe renal impairment less than 15, switch to warfarin. Active clinically significant bleeding, condition with significant risk major bleeding like GI, ulceration, recent brain or spinal trauma, concomitant treatment with any other anticoagulant. Very important. Sometimes we don't need to combine DUAC with aspirin or apixaban. Many times, anticoagulant medication is adequate, but there are indications for compelling, dual antithrombotic medication. Concomitant treatment with any B-glycoprotein inhibitor, prosthetic heart valve requiring anticoagulant. This we cannot use it, and antiphospholipid. So these are the medications that interact, maybe are better. If I have, usually I consult clinical pharmacist in our clinic to make sure that drug interaction with the DUAC is important, but the common, medication like anti-retroviral, anti-fungal, medication, anti-TB medication, they do interact with the DUAC. The food, very important, just rivaroxaban that we use it, we advise the patient to take it with food to enhance absorption, like if it is 5 milligram BID, like in Ramadan, we ask to take it with the breakfast and sahur. If it is once daily, like we ask them, like 20 milligram with the breakfast. Other medication, apixaban, the bigatran, take it with food or without food. There is no any interference with that. Duration of treatment, IE is not associated with environmental risk factor. We call it idiopathic. We treat indefinitely. So that's the duration of treatment, and always balancing the risk of recurrence without anticoagulation, and patient and physician preference is very important. So very important practical point, if the patient before a blunt surgery, this is rule, remember it. It has to be, we say 24 hours before and 24 hours after if it is low risk bleeding surgery. This is standard risk bleeding. If it is high risk bleeding surgery, we stop it 48 hours before and 48 hours after. And this is based on the surgery related, risk of bleeding. So high risk, like this is major cardiac surgery, orthopedic surgery, cancer surgery, urologic, and this is important, the low risk. So like upper, lower GI endoscopy, so this is gastroscopy, hernia, cholecystectomy. This is the list is long, but remember, this is, you stop it 24 hours before and 24 hours after. High risk, 48 hours before and 48 after. This is just to make it easy for people. So dental interventions, Skin surgery and cataract surgery, you don't need to stop anticoagulation. You should resume. Remember, if dental intervention, just avoid being in the peak, like 2 hours after the drug. We advise to have the dental intervention in the trough level, which is the least drug level. So do you need to monitor DUAC? We don't need to monitor unless you have serious bleeding and thrombotic event like breakthrough, urgent surgery, renal or hepatic dysfunction, potential drug-drug interaction, and suspected overdosing. Just important. That's when we say monitoring, mean measuring the effect of the drug and adjusting the dose. Here, what we say, this is a quantitative measurement of the drug exposure. This is the how to monitor for dabigatran. We have dilute thrombin time and carrying clotting time for apixaban, edoxaban, rivaroxaban, chromogenic anti-10A. We don't use PT, INR for monitoring of apixaban, edoxaban, rivaroxaban. Although they are, you will find them elevated in this patient. We call it sham INR, falsely elevated INR. It's not genuine or true INR. If you have bleeding, you just need a classical approach. There are direct antidote for these patients, like for monoclonal antibody for dabigatran, idarucizumab, or recombinant factor 10A, andexanet alpha. We use it for rivaroxaban and rivaroxaban and apixaban. And we have non-specific reversal agent. This is what I'm using available in our hospital. 4-factor BCC, like Briplex or Octaplex. We use it for reversal of factor 10A inhibitor with excellent efficacy and safety. In all patients we have used, about success rate of reversal about more than 70%. If you have any like tonsil pharyngitis, you can use antibiotic with DUAC, no problem. Very important point that if you have a patient on warfarin, the least drug that interact usually cephalosporin, and you can use also amoxicillin. But augmentin, it has significant drug interaction. Just to conclude that patient journey on anticoagulant therapy through different healthcare setting, as you have seen, is safer with DUAC than vitamin K anticoagulant therapy. And really, I lived the era of vitamin K antagonist, and I lived the era of DUAC, and I see it is really more comfortable, more convenient for patient, for healthcare providers. And in the clinic, we see more patient like before. Before with VKA, we have more congested clinic, more disorganized. Now it is the flow is easy. And I think this is really the major revolution for thrombosis. Thank you for your attention.
Thank you, Dr. Mohammed. And actually, we start at the beginning with introducing everyone of the team, and I think at that time technical issues was there. So Dr. Mohammed is assistant professor of internal medicine, and he's consultant of internal medicine, thrombosis and vascular medicine, King Fahd Medical City. Thank you, Dr. Mohammed. It's amazing talk, really, and it's covered a lot of things. Personally, being cardiologist, most of the time we are dealing with the other part of the story. Informative lectures for me. Thank you so much. So now we will go back to the questions. So I think Dr. Mirvat already, she answered some of the questions. Some of them it's really interested. So maybe we will go through. One of the questions was regarding the NOAC. So are better than warfarin, but what do you think? Which of NOAC is better? So if we compare them head to head, and that question was from Prof. Mustafa Shimeri. So if you can answer, so people can hear the answer. I know you answered it already on the system.
Yes, so we don't actually have head-to-head comparisons, and we have to be very realistic. Every hospital is going to have its own formulary. Very few centers or hospitals are going to have all three NOACs. So for real practical purposes, you're going to have to see what formulary is actually available in your own hospital or individual hospitals. But if you have to individualize a decision, I kind of tried to walk you through it during the course of my presentation. So for example, not the NOACs are not all the same. So if I have a patient who's had a prior history of GI bleed, for example, I know that I'm not going to prescribe something like a rivaroxaban. The data is clear there that the risk of GI bleeding is higher with rivaroxaban. So the point is, tailor it to the individual patient. If you have the option and you're not restricted by the formulary of your own hospital, tailor it to the individual patient that you have. So there are some ongoing trials and there are some meta-analyses that were done, for example, in elderly or patients with renal dysfunction. And, you know, there's a lot of talk, for example, with renal dysfunction, that if a patient has a renal dysfunction, they were excluded, especially with advanced renal dysfunction, they were actually excluded from the DOAC or NOAC trials. That's correct. But for the record, they were also not studied for warfarin. So many people will, by default, give warfarin under the assumption that, well, they were excluded. But there's some data that was published in JACC in 2017 that actually is a real world data. And they looked at patients who had renal dysfunction and were still given a DOAC, and it was safe and it was efficacious. So if I have to choose what anticoagulant to give a renal dysfunction patient, I would choose a DOAC over warfarin for sure. The calcification and so on, and the safety profile is very, very different.
Great, yes, I agree with you. So, Dr. Fakhr, one question asking about which NOAC you could prefer in a patient with chronic kidney disease.
Well, according to the data, as we all went through, Dr. Amir and Dr. Sheef, that it depends on which stage are we talking about in the kidney failure or the kidney disease. If it's a severe kidney problem, none of them. If it's from 15 to 30, as shown by the studies, the apexapan would be the safest in this case with a lower dose. And this is the one available in Saudi Arabia. It's not available. So most probably it would be the apexapan with a lower dose.
Great, and I can see that all the experts here so agree with you. Dr. Mohammed, one question asking about, is the size of stroke affect the decision of anticoagulation regarding use of which of them? Is there a preference, one better than other, or what do you think?
Just to make it clear, so for stroke prevention and atrial fibrillation, so this is the question. What's the best drug for SPAF?
Yeah, if a patient with atrial fibrillation who had a stroke already, so status post-stroke, that's what I can understand from the question. It was not clear.
Mm-hmm. Yes, let's say, so if it is post-stroke, so we don't initiate anticoagulation immediately because of the risk of hemorrhagic transformation. Usually they start just aspirin after 5 to 7 days. If they repeat CT brain, if there is no expansion of the, like hemorrhagic transformation, they can use DOAC, either DOAC, rivaroxaban, or apexaban. They showed excellent efficacy and safety profile, but definitely is not recommended to be started immediately. And sometimes, based on the size of the stroke, if it is mass initiation of anticoagulation more than a week. And remember, the daily risk of stroke is low, so it's safe to wait for a week or more.
Great, great. Dr. Amir, one question asking about those patients who are presented with ischemic heart disease and they are a known case of atrial fibrillation on NOAC already. Question is the duration of the triple therapy. I think you answered through the presentation about that, but if you could focus on that again for that question.
Right, so two ways to look at it. One, you have to look at the acuity of the case, so if it was an elective or staged PCI as opposed to an acute coronary syndrome, and how complex the intervention was, if it was a complex intervention, and if you were using first-generation drug-eluting stents or not. So very PCI-related issues. The guidelines currently say for a acute coronary syndrome, you continue triple therapy from 3 to 6 months, after which dual therapy, and these are the European guidelines, and at 1 year, you continue with monotherapy for life. Bear in mind that there are ongoing trials now for drug-eluting stents, and antiplatelet regimens that are abbreviated. Several stent platforms are being tested with abbreviated antiplatelets in high bleeding risk patients. So elderly patients, patients who require anticoagulation for AF, for example. Those have not been published. They have completed the randomization, and probably in the next couple of years, we're going to have a lot of these coming out. And they will hopefully help us reduce that initial period of triple therapy.
Great, great. Dr. Fakhr, from the experience, from the evidence-based medicine, what about NOAC and LV? NOAC and LV dysfunction. Those patients with LV systolic dysfunction.
I think it's if the patient having indication for anticoagulation, like VTA or unusual site thrombosis with LV dysfunction, they are doing perfect. I have, seen many patients in my clinic, cardiac patient with, non-cardiac indication for anticoagulation and doing perfectly well. Even it is off-label use LV thrombus. I have seen many patients with LV thrombus on DUAC, and they are doing perfectly well, although this is off-label indication. So I don't see any problem, but you have to make sure that renal function, adjust the medication to renal function, and try as much as possible to avoid dual or triple antithrombotic medication unless it is strongly indicated, because I have seen bleeding, major hemorrhage in cardiac patient on triple antithrombotic therapy, and I've seen them like after 1 year of stent, etc. I think this is area we need to, like in the clinic, the clinical pharmacist, the cardiologist, or if they come to our thrombosis clinic, always we have to make sure there is whether we need to continue dual anticoagulant therapy or not.
I would just also like to add a point here. We have already scattered information from our centers, and I'm sure other cardiac centers regarding the DUACs. All of them are effective. As Dr.sheef said, we need to monitor the patient with an echo before and after when you give, especially for the LV patients, because the target's supposed to be reached. You don't put the patient on it and just leave them without a monitor. That's the crucial thing. That's the key point of using such a medication. And I agree with you. Any one of them could do the job. It depends on the proper dosing and the proper follow-up.
Okay. Dr. Marvin, have you used the NOAC in a patient with LV thrombus?
I'm sorry, was that directed to me?
Yeah, I'm asking about the LV thrombus and NOAC. Actually, both of our speakers, they mentioned that they can be used as off-label, but I mean, as a practice, have you used that?
So it is an off-label use. It is actually mentioned in the AHA-ACC guidelines for TIA, stroke prevention, but it's mentioned as an alternative to warfarin. So it's an alternative to vitamin K antagonist, not as the preferred, primarily because we don't really have some data. There was a very recent publication, I believe, in JACC about use of NOACs in LV thrombus, and it wasn't favorable. So although many of us would have preferred, myself included, because it, once you have a patient who has completed their MI, you want a bed turnover and you want to be able to send your patient home. And if they have an LV thrombus and you're still going to start anticoagulation, particularly patients who are far away, you can't tell them just go home and follow up with the anticoagulation clinic. So a lot of the times we're forced to keep the patients an additional day or two in the hospital just simply to monitor their INR and send them off with a therapeutic range on warfarin. But I think the preliminary data is not promising in this area.
Okay. There is a question here, and the one who asked, it's actually mentioned that to Dr.sheef, a patient with DVT and non-valvular atrial fibrillation, which NOAC would you like to start?
I mean, there is no head-to-head comparison between the DUACs. And remember, the population, they have different inclusion criteria, and they have different, clinical characteristics. Maybe there are some, studies have high-risk patients, some they have intermediate risk or low risk. From my clinical experience, the most common two DOACs I have used, apixaban and rivaroxaban for treatment of venous thromboembolism. If one of the speaker, mentioned if a patient with high risk for GI bleeding, you might favor apixaban because rivaroxaban can increase the risk of GI bleeding compared to apixaban from clinical trials and from clinical practice, from our observation. So it's case by case basis. If the patient is really willing to use drug that once daily is strongly motivated, so you have to discuss with the patient the options, the pros and cons, but there is no one drug is superior to the other drug. The two DOAC are fine for me, but important, it's just check the duration. If it is a provoked, treat for 3 months. Don't extend anticoagulation duration.
Okay. Another question, Dr. Omer, but regarding the role of anticoagulation in a patient with atrial fibrillation status post ablation therapy.
Yeah, so ablation for atrial fibrillation, I'm assuming that's the ablative therapy. So the success rate for ablation varies from center to center, but generally it is not 100%. It's generally in the area of 60 to 80%. So before taking patients off anticoagulation, you need to make sure that they have actually been cured. And so what we do in our center is after the ablation, we keep the patients anticoagulated for at least 6 months, and then 3 to 6 months, and then the anticoagulation is discontinued if no recurrence happens.
Great. Another question, Dr. Fakhr, about the timing. What's your advice regarding timing of the doses of NOAC if it's BID during Ramadan, while we know that the duration can be more than 12 hours?
That's a very nice question. That's what we stated it in the Saudi Heart Association site about using DOACs in Ramadan. The difference between futur and sahur is almost like 12 hours. And what's happening is that we tell the patients you should take it not less than 10 hours, but not more than 14 hours. That's the key point. Again, we cannot tell the patient that if you miss a dose, you just go ahead and you just skip it unless there's a space of taking it again. What I mean, most of the time we tell them take it in futur, which is most of the time all of the patients will take it. Now, the other one's supposed to be after 12 hours, but even if it's 10 hours, no problem, at least for the fasting area. After that, some of the patients, they come and say, I remembered after khalas, sahur, like he's already fasting. I can't tell the patient, well, okay, break your fast and take it. What we do usually, we say, khalas, once your fatur again is coming back, you take it. This is how we advise the patient.
Great. Dr. Mohammed, one question regarding one of the attendees asking about a personal case that the sister had an antiphospholipid syndrome and she's taking Warfarin. So the question is, can be on NOAC?
Yeah, that's a very important question. We know that antiphospholipid syndrome is heterogeneous syndrome, i.e. You can have antiphospholipid syndrome with single positive antiphospholipid antibody. You can have dual positive antiphospholipid antibody. You can have a triple positive. There is clinical implication for this triple positive antiphospholipid syndrome, like positive anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant. If the 3 antibodies are positive, this is what we call full antiphospholipid antibody profile. This is a high-risk group of patients. All of them, they fail DOACs, and the drug of choice and the standard drug and the safest drug is vitamin K antagonist. Regarding single, positive antiphospholipid antibody syndrome, I have a patient in my clinic doing perfectly well more than 5 years. For dual positive, I can say this is again, it is like intermediate risk group. So let's take it for clinical studies. They have conflicting results for clinical trials. you have the latest one in published in Annals of Internal Medicine. They mentioned that rivaroxaban, like DOAC, is not inferior to vitamin K antagonist. However, there are previous studies showing that rivaroxaban or failed in prevention of VTE. So you have conflicting, result. But remember that Saudi FDA, they have, sent memo for all physicians practicing, thrombosis to sign that not to use DOAC for anticoagulant syndrome because of the risk of recurrence. Let me tell you about my own experience. I have used DOAC. We have like a clinical study. We use DOAC, like rivaroxaban for anticoagulant antibody syndrome, about like 40 cases, and I have seen cases. I said double positive have high risk of recurrence. If they have VTE before starting DOAC, have risk high. Now, Atrial thrombosis, they can get after 1 year or 2 years. I will be, so I decided to use VKA for all patients, all anticoagulant antibody patients, just to be in the safe side. So this is my recommendation. Step 6, not use VKA for anticoagulant antibodies.
Dr. Raed, you need to unmute.
Oh, sorry. Dr. Mohammed, regarding the COVID-19 and the risk of thrombosis, any special consideration in relation to anticoagulation those group of patients?
Yes, we have created a protocol for VTE prophylaxis anticoagulation COVID-19. So this protocol was, made in collaboration with our clinical pharmacist, infectious disease consultant, and a thrombosis. So we, based on the, the clinical, we have like tsunami of clinical research of COVID-19. So you have to be updated every day. You have publication. It's very difficult to cope with. So based from the literature, published about COVID and thrombosis, we know that COVID-19 is hypercoagulable state. This is a matter of fact, and you have seen many cases of thrombosis, arterial, large vessel stroke, or you can have venous thromboembolism. So we said that all hospitalized patients with COVID, they should receive routine standard VTE prophylaxis, all of them. So this is number one. Then we say, based on the D-dimer level, if it is more than 4 to 6 times of upper limit of normal, if it is like elevated 4 to 6 times upper limit of normal, you need to give them half therapeutic dose. Like phenoxypyrin, not 40 enough, like half milligram per kg BID, like medic 40 BID or 60 BID. And if they have high index suspicion for VTE, but you cannot, perform confirmatory testing, you can use therapeutic anticoagulation. Typically, patients who have a pneumonia that is improving, like radiologically improving by X-ray, but clinical, there are more requirement for FiO2. So you need to anticoagulate. This is really, I have just last week, we have unfortunate young patient who was previously healthy, presented with massive pulmonary embolism, very massive obstructive shock and stroke, and test came to be positive for COVID-19, unfortunately, after the death of the patient. So really, what's the mechanism of a thrombosis? We think it is linked to the, inflammation, cytokine release syndrome, and coagulation activation. That's why we have D-dimer is very high, in spite of the DIC marker low. Like you can have patient platelet normal, you have PT, ABTT slightly normal, but D-dimer is sky high. So it's very unique. We think it's like from pulmonary intravascular coagulopathy. It's very complex, but thank you for asking this question. I will prophylax all of them. Okay.
Great.
I just want to add a point, Dr. Raed, regarding this question. It's a very nice question.
Yes.
We found that there's also an interactions between the drugs given for COVID, the antiviral medications, and the anticoagulant. So also that is another problem. We are facing 20 to 25% increase in the anticoagulant efficacy on those patients. That's why we sometimes have to even advise for the factor 10, sometimes monitor if he's on the direct ones, or sometimes the full picture PT, PTT for the dabigatran one. But again, I really advise that, as Dr. Sheef is telling us, we have to monitor the levels, the efficacy, and the bleeding sites. Where is it, and what's happening in the COVID patient?
Last question, Dr. Marbat. One of the patient is asking, do you use any special measures to avoid radial thrombosis being interventionist?
Radial thrombosis?
Yeah.
Well, yeah, we give heparin up front, whether it's diagnostic or a PCI, whether it's an intervention. So we have to give heparin even for diagnostic cases. But actually, the most important is trying not to damage the radial artery as you're going in, and what we call patent hemostasis. So not completely occluding the radial artery to maintain a little bit of patency, but at the same time balance it against hemostasis. And those have actually, that in particular has shown that it actually reduces the rate of radial artery occlusion subsequently.
For all of you, and at the end, كل عام وانتم بخير وتقبل الله صيامكم وطاعاتكم. I'm really so happy to be a part of this amazing webinar. Would like to thank the clinical pharmacist group out of Saudi Heart Association. Really, they were very active during this Ramadan. Really, thank you so much for this opportunity. Thank you for Pfizer for sponsoring this meeting. And thank you for our great attendees. Some of questions actually not answered. We will try to answer it offline, inshallah. Thank you so much. وليلة سعيدة لكم جميعا إن شاء الله.
Thank you very much. Thank you.
Thank you.
See you after Eid, inshallah.
inshallah. inshallah. حفظكم الرحمن.
السلام عليكم.
كمان الله. وعليكم السلام.
السلام عليكم.